this idea of, oh, I'll wait to get a period, or I don't have any periods, therefore I have no chance of getting pregnant, is not true. On the other hand, it is much less likely to get pregnant if you are not having regular periods.
You're listening to the Digest This podcast, and I'm your host, Bethany Cameron. Conceiving naturally is a hot topic in this day and age, and IVF has skyrocketed as the go-to method of conceiving for couples. But is that the best option? And should we be looking at other variables before spending our time and money on IVF? Natalie Crawford is here with me today to talk all things infertility, biomarkers, healthy habits we may be doing that are actually hindering a woman's chance to conceive, and so much more. Natalie is a double board certified fertility doctor and has helped thousands of patients and followers learn about their bodies and their fertility, empowering them with education and learning to advocate for themselves in their own fertility journeys. Today's discussion is an eye-opener for anyone trying to conceive naturally or via IVF. Natalie breaks it down and advocates for both because not one's couple fertility journey is the same. I know everyone who listens will be obtaining valuable information from this episode, so let's dive right in. I have a question for you all. What's antibacterial, antimicrobial, anti-inflammatory, contains antioxidants, improves oral health and digestive support, and contributes to wound healing? If you guessed Manuka honey, then you're absolutely right. Every time I talk about Amenorrhea honey from New Zealand on my Instagram, I always get messages from my followers telling me how much they appreciate me introducing this ancient healing honey to them and their family. A little goes a long way, and this honey should be saved for medicinal purposes, not baking into cakes or cookies. It's something I always have in my pantry because it never spoils, ever. And a tiny teaspoon daily is all you need to get the endless benefits both internally and if you apply it externally on your face for breakouts or even burns, its potent healing powers work wonders. Amenorrhea honey contains 3 times more antioxidants than your typical sweetener and the special antibacterial compound called MGO. The higher the MGO count, the more of these antibacterial compounds exist in the honey. It's hard to find Manuka honey with an MGO above 500, but Amenorrhea guarantees an MGO of at least 850. Now it's easier than ever to get Amenorrhea honey. Just head on over to amenorrhea.com/digest to save $70 on their starter kit, which comes with an 850 plus MGO Amenorrhea honey jar, 5 honey travel sticks, a wooden spoon, and a guidebook. That's amenorrhea.com/digest to save $70 plus $25 worth of free gifts. That's amenorrhea.com/digest. What's your love language? Mine is food, and so is my dog's. This is a huge part of how we can show affection to our pups, and they know it. Another way to care for your furry friend is by giving them good health, and that starts by what they eat. So why not combine the two by giving them tasty, delicious food that's actually good for them, not just now, but for the long term? I want to keep my dogs around as long as possible, and I'm sure you do too. That's why I give my pups fresh, living food from Ollie. Ollie offers human-grade recipes backed by vet nutritionists and crafted with culinary experts, and each meal is tailored to your dog's specific needs because not all dogs are the same and each requires certain needs, just like humans. Our dog Pepper, who is a toy Yorkie, and our dog Sadie, who is a Belgian Malinois, both love Ollie's variety of meals to keep things fresh with a variety in their diet. How would you like to be fed the same thing every day for years? Not fun, not exciting, or it's not even good for you. We all need variety for optimum health, and so do our pets. Their favorite is Ollie's beef and sweet potato meals, and the lamb and cranberry recipe comes as a close second, followed by their turkey with blueberries, and of course, the chicken and carrots is always devoured too. Show your dog some love in the way they understand best. Head to ollie.com/digest, tell them all about your dog, and use code DIGEST to get 60% off your welcome kit when you subscribe today. Plus, they offer a happiness guarantee on the first box. So if you're not completely satisfied, you'll get your money back. That's OLLIE.com/digest and enter code digest to get 60% off your first box. Okay, Natalie, you're here to talk all things fertility, pregnancy, hormones. But before we get started, I have a few questions, and I like to start my podcast with rapid fire yes or no. So you can only answer yes or no to these questions. Are you ready?
I'll try.
All right, first question. Can gut issues cause infertility?
Yes.
Should we be preparing for bearing children in our teen years?
Yes.
Can stress alone cause infertility?
Yes.
Is inflammation in the body causing infertility?
It can be, yes.
Okay, all right. Last question. Can you still get pregnant if you don't have a period?
Yes. Asterisk.
Okay.
Some circumstances, but yeah.
Let's dive into that because I've actually known some people who got pregnant and they didn't have a period, and I was like, what? So, all right. So why don't you go, first of all, introduce yourself. Tell my listeners who you are, what you do.
Thank you. I am Dr. Natalie Crawford. I'm a board certified reproductive endocrinologist, which means that I had training in both OBGYN and then did fellowship training in reproductive endocrinology and infertility. And I have a practice in Austin, Texas called For Fertility. And I have a new book called The Fertility Formula, where we're probably all the things we talk about today are in much more detail. But essentially, it's a book helping us understand our cycle, our hormones, our fertility, and how a lot of the world around us, including inflammation, can really impact our chance of success. So thank you so much for having me, and I'm honored to be here.
Yeah.
Okay, you want to dive into how you can get pregnant without a period?
Let's just do it. Yeah, go for it.
Okay. I think the heart of this question is you have to understand what is happening within your menstrual cycle. And so the short answer, and then I'll expand upon it, is we ovulate as the stimulus to then later get a period if you do not get pregnant. So before you ever have your first period, you will have ovulated, meaning you can get pregnant even if you've lost a period or it's irregular, because you'll ovulate again before you, quote, start getting periods back. And so this idea of, oh, I'll wait to get a period, or I don't have any periods, therefore I have no chance of getting pregnant, is not true. On the other hand, it is much less likely to get pregnant if you are not having regular periods. So that's why I gave it lots of asterisks when you ask the question, can you get pregnant without a period? You can, even though that's not going to be the most common thing. Much more commonly, if you don't have a period, it's going to be much harder to get pregnant. But when we think about the menstrual cycle, what I think is just important to set the tone for what we'll talk about is that you have all the eggs you're ever going to have. I want you to envision them in a vault inside your ovary. And every month you have a group of these eggs coming out of the vault. And what's happening on a cellular level is that each egg grows inside a follicle. The brain sends out follicle stimulating hormone, or FSH, which is well named, gets a follicle or an egg to grow. That makes estrogen. And this is called the follicular phase. This is when the lining's growing, you're making estrogen, you have yet to ovulate. So the brain will then send out a surge of LH, or luteinizing hormone, when that egg is mature. And it knows this based on the level of estrogen it's getting. That follicle will then rupture, the egg will be released, and that's ovulation. And then the follicle will reform and become a corpus luteum, which now is going to make progesterone as we enter the luteal phase. And the luteal phase is the second part of the cycle. You're now making progesterone in preparation to get pregnant. And if you do not get pregnant, the corpus luteum can only live at max for about 2 weeks. It then will die, progesterone will drop, and you'll get a period. And so we have to ovulate to get a real period. Therefore, if you're having intercourse around that time of ovulation, even though you haven't had regular periods, you absolutely can still get pregnant. But the egg only lives for 24 hours. So we know the odds of success from a single active intercourse. You can actually only get pregnant the 5 days before and then that day of ovulation. Sperm can live for 5 days in the body, the egg only 24 hours. So hitting that, if you have no idea when that is happening, is possible, but it's less likely. And that's why getting somebody to have regular cycles or really learning to track our cycle are really important steps if we are trying to get pregnant.
Okay. I love that explanation because to my understanding, you can definitely be ovulating and not have a period. I've had friends, they're like, I'm pretty sure I'm ovulating. Like they check their cervical mucus, like all of the things, but they're like, I haven't had a period. Like it's just kind of random. That's one friend. And then I've had a few people actually get pregnant because they weren't having a period because they had actually just given birth. And it was like 1 year out from giving birth, and then they got pregnant again. And they're like, I haven't had a period since prior to my first child. And here I am with a second, on the way.
We always have to warn people about that postpartum because, again, before that period comes back postpartum, at some point you're going to ovulate first. So if you're just having sex and not using any contraception, you very well could get pregnant before that period ever comes back. And then to the first friend that you had, one of the top reasons we see that ovulation with no period in that circumstance is from prolonged contraception use, especially the birth control pill or a progesterone IUD. That can significantly thin out the lining and take a really long time to come back. Even if you're ovulating, it can take many months of estrogen exposure again to get the lining thick enough. And I guess the third scenario would be prolonged hypothalamic amenorrhea, where your brain wasn't sending out hormones. Maybe you were exercising a lot or an elite athlete or had an eating disorder or not eating enough. In those circumstances, even when your hormones have to normalize and you have to start ovulating before you'll get a period. So there's this transitional zone where the lining hasn't seen estrogen for a long time and you might ovulate without having that bleed. So there's always special circumstances we have to be aware about for our body.
Yeah. I've heard that too about elite athletes. And because they're just so fit, so lean, they don't have a period. And like for years, because they're just in that, like they're a runner or whatever. And then they get pregnant still. It's kind of weird.
It's interesting, but yeah, the brain, it's called hypothalamic amenorrhea in that circumstance. The hypothalamus is the area of the brain that I consider central command station, constantly interpreting these hormone signals that it's receiving and deciding, let's send out FSH, let's send out LH, let's send out whatever hormone. But the woman's body is so fascinating, beautiful, and interesting. It's made to get you pregnant. That doesn't mean you have to get pregnant or that that's our only function, but pregnancy is such a huge metabolic spend that your body wants to protect you first. So it's making sure that you are in a good state of health, for lack of a better way to say it, to get pregnant. And so times where maybe you are extremely stressed or you go through something traumatic or you're exercising intensely because you're training for the Olympics or you're not eating enough calories, your body is getting a variety of different signals back from your hormones, your cortisol, your inflammation, your insulin. And it might say, gosh, I'm not convinced that Natalie can support a pregnancy right now. Maybe we should change how we are sending out hormones because she's having a hard time meeting her daily needs. And then it can take a while to turn that back on. So there's different circumstances that can cause that to happen. But that's also the heart of one of those questions you asked, can stress alone cause you to have infertility? And even though it's typically not stress alone, but there can be very huge traumatic life stressors that absolutely can shut the brain off from a certain moment and prevent you from ovulating. And it can take quite a while of recovery from whatever that is for you to feel more stable, or for your brain to say, okay, now this is past us enough and I feel good resuming ovulation and us getting pregnant. And we see this even with PTSD, people who've gone through traumatic life events in the past. And on a real tangible level, chronic stress itself contributes to chronic inflammation and insulin resistance. And that absolutely can have metabolic impacts on our fertility. So it's one of those things that many times gets dismissed. If somebody says, I'm feeling really stressed, she might casually hear, oh, don't stress about being stressed, or, oh, stress plays no role. I really am over the era of dismissive comments to women who are suffering or admitting that something doesn't feel right in their body. I feel like this is the era of, I view my role as trying to explain how your physiology works, things that can influence it, both positively and negatively. I give you data and you make decisions. At the end of the day, I'm not here to tell you how to live or what to do, but you can't make decisions on data you don't know. And that's an opportunity for us to help educate when it comes to stress, for example. Well, stress can be problematic. How can we start to combat this and what can we do? And that's the better discussion to really have.
Yeah, and I love that you're working with the patient, because I think that so many practitioners these days, they just put you in a box. Oh, you can't get pregnant. Okay, go to IVF. Like that's the first thing, is just, oh, okay, you're having infertility issues or fertility issues, IVF. Like they don't explore other options before going that route. And so I want to get into IVF, and if you would recommend it, or when you would recommend it, and when you would first go through other options.
Bethany, it's a really great question. And I want to be clear. IVF is incredible. It's helped so many people have babies. Over 17 million babies, worldwide have been conceived through IVF. And there are some circumstances where people will not conceive without it. So we never want to discredit it. In the same breath, the decision should not be algorithmic, meaning you must do XYZ before you get here, nor should it be we push you here. We see women at a variety of different circumstances, whether it's their age, their medical situation, their own timeline, what's happening in their life, their partner. And so we need to individualize and personalize this approach. Sometimes I see patients and IVF is the next step for whatever reason. Maybe we want to do the thing that will get us pregnant the fastest. Maybe it's our desired family size. Maybe it's a diagnosis. Sometimes we're trying to do things in a lesser aggressive fashion, or our timeline feels like we have more space in it. So I always want to not shame anybody to feel like there's a certain thing we should do. There's no right decision. Our goal should be to present the options and understand what's the recommendation based on your goals and your circumstance. To put it plainly, IVF is trying to get the eggs that we have available in one given month, those eggs that have been sent out of that vault, to grow. We said earlier, one would ovulate and the rest of them would die naturally. So we're going to say for this 1 month in time, I want to give all of these eggs the opportunity to grow. And so what we do in that month is we take injectable forms of FSH, the same hormone the brain sends out, trying to get all of those eggs to grow. We then will take them out of your body, can fertilize them with sperm, and grow them in the lab to get to the embryo stage. We then can do genetic testing, freeze the embryos. We can then have a bleed and then synchronize your uterine environment with an embryo, thaw it, and put it in your body. And really, to kind of lay it straight, it allows us to have improved selection. We're not involving the randomness of your body. We're able to kind of give all eggs a chance to see which ones are the best. We're able to put sperm in an egg, we can choose the better sperm. We put them through a little, I call it a sperm obstacle course. They get challenged in the lab. We can then pick the best one up and put it inside an egg. We can then grow embryos in an environment that is not in your body. And the IVF lab is non-inflammatory. It's the perfect environment. So we're optimizing conditions for embryos to grow. And then doing genetic testing allows us to select those with the highest potential. And then getting the uterine environment perfect allows us to synchronize this. So an IVF success rate for a single genetically normal embryo is 65% per embryo, which is really incredible, but not near 100%. And I think this is a really important discussion to be had, because natural conception, what are your odds of getting pregnant if you are 30 and you're having intercourse chiming it? At best, it'll be 20% per month. And then the longer you try, the lower that number gets. So we see women who are older get pregnant without IVF. We see women who are younger need IVF, right? There's no one universal recommendation here. But across all the different stages, IVF is going to be a more efficient way. And it's the only treatment we have which exceeds whatever your age-related natural conception rate is, right? It's the only thing kind of improving upon that. 65, as we said, is not everything, not 100%. We can improve that number by having more than one genetically normal embryo, because if the cumulative success rate after 2 embryo transfers is over 85%, and after 3 is almost 95%. So that's a real good number. If I sit here and say, hey, 95% of people are going to be pregnant within 3 embryo transfers, but not everybody can make 3 genetically normal embryos. And the odds of that are easier the more eggs you have and the more that are genetically normal, which is correlated with both how old you are and then your egg and your sperm quality. And those are variables that you do have some agency over, how you have, how your eggs grow in your body, how much inflammation you have. Similarly, sperm are highly, highly sensitive. So that's why I think it's really important that we start to say, even if you're doing IVF, understanding your body, how it works, understanding the factors, the lifestyle things that can influence inflammation, insulin resistance, and then egg and sperm quality really are essential because IVF is expensive. IVF takes time. What I just walked you through sounded really fast, but that's about 4 months of your life. And it's physically and emotionally a lot. I don't think we should have to go through a cycle, have a bad outcome, then be in a position to say, I think it's your egg and sperm quality. Now go make XYZ lifestyle changes, and hopefully we have a different outcome. And I've seen this play out maybe where the most common scenario right now is male partner using cannabis. So we go through a cycle, should have good outcomes. We see the embryo stop developing on day 3 of embryo life. And that's when that male genome kicks in. When we sit down for our what happened visit, then it's disclosed that we've got cannabis use that we previously, didn't admit or didn't want to change or didn't think was important. And we may change that variable, wait a few months and do another cycle and have completely different outcomes. So just showing how impactful the environment can be on both eggs and sperm. And I think that's information we should focus on earlier. So IVF is amazing. It's wonderful. It's helped so many people. And there are scenarios where it is the thing. Severe male factor, tubal disease, really terrible endometriosis sometimes, genetic factors. There's a slew of circumstances where somebody might be in a position that, regardless of their age, IVF is the right choice. There's also circumstances where we start seeing maybe we chase career dreams, or we met a partner later, or we want to maybe not give up this dream of a certain family size just based on our age. Because for all of us, we do reach a point where our fertility does cease. Fertility is finite. And so looking at the reality of the time it takes to conceive, being pregnant for 9 months, recovery, getting pregnant again. If you don't meet your life partner until 38 and you want 3 kids, it's not that it's impossible, but it is less likely to happen unless we intervene with reproductive technology. And then with that, the sooner we do, the better the outcome. Meaning, I tell patients sometimes you could run a 5K or a marathon, and people run marathons every day. So you could do either. But if we get the choice, running a 5K is easier. And that's what we should start to kind of view and look at. And sometimes that is by thinking about our full family size, getting an evaluation of our fertility earlier, holding space for this discussion so that we're not in that position to say, gosh, had I only known that earlier, maybe I would have made a different choice, which is something I hear patients say every single day.
Yeah. I have a few questions. So you brought up cannabis.
Yeah.
Now, does that also include CBD, or are we talking like true weed here?
It's a really good question because it's really mixed in studies, right? I think we know that, THC, especially, in edible form and, gummy form, cannabis and marijuana, that all appears grouped very negatively on the impact of eggs and sperm. CBD oil, like what is that? Like many studies are not differentiating that level. And if this is one of the problems when a substance has been limited in the past, historically, we don't have as much data on it. Depending on who you are, where you are in your life stage, like if you're going through IVF, I'm going to tell somebody to be much more conservative and don't use any CBD products because it's not worth potential harm, right? If you're like, oh, well, I haven't started to conceive yet, then you can make your own choice. So we might choose to look at one risk differently in the absence of data, but all the data we have, with THC products is definitely that they are negatively impacting both eggs and sperm. And that can be reversible, but you have to stop use.
Okay. Yeah. I just wanted to clarify because there's a lot of CBD products out there without THC. It's like, and a lot of people use it for pain, sleep, like
relaxation.
Yeah.
I know. I think we just have to say right now it's a little bit of a gray zone. So it might depend on your circumstance, how you feel about that.
Okay. And then also, I just want to bring up the issue I have. One of the issues that I have with IVF is that people go into it, they're not healthy enough themselves to carry a baby because you will ultimately carry that baby, right? Like maybe they're having some health issues and they can't get pregnant because of the health issues. So they do IVF, they have success with it, but now 9 months, they're having to carry this baby, but their personal health issues are still not resolved. And that can, trickle down to the baby, not giving them enough nutrients. Maybe they're having trouble absorbing vitamins and you know what I mean? Like they opt for IVF because of their health issue where they're still going to have to carry that baby for 9 months. So that's my whole concern.
I think two things can be true at once. I completely agree with you. I view infertility in general as a symptom, not just a disease, meaning oftentimes for women who have had no diagnosed medical problems in the past, this is that first time your body is challenged in such a way to say, oh, I'm not getting pregnant. And this is a representation of metabolic dysfunction, insulin resistance, these other problems that if we give somebody the opportunity, well, one, they're not being diagnosed. They're being told just do IVF. They're not even given the opportunity to address them. So that's a problem. But two, sometimes we have to do IVF. Sometimes we have a cancer diagnosis and time is on the clock and we've got to do it right now. Or sometimes I see patients who have an insurance benefit that this is about to expire and this is the moment. What I like to say though is the time sensitivity is always having to be balanced. But sometimes, and I have a group of patients like this where I say, look, egg quality is influenced by these factors, but success with the embryo transfer and ultimate pregnancy success are influenced by them even more. And so sometimes we go through IVF and we stop and we say, hey, we have to address XYZ before we do the embryo transfer. So if we want to think about IVF in vitro fertilization, get eggs out of body, fertilize in the lab. FET is the frozen embryo transfer. It's our due diligence to try to put that embryo back in when not just has the highest chance of implanting, but you have the highest chance of a live birth, having a healthy baby. And of course, there's so much data about epigenetic changes and how maternal health influences long-term health outcomes for the baby as well. So I don't love universal statements, IVF is good, IVF is bad. But I think your core point is so important that if we view infertility as a symptom, therefore there's a reason why you might be in this position. You still might choose to do IVF, but addressing the underlying root cause of what's getting you here anyway is so essential, not just for your outcome of getting pregnant, but also for the baby's long-term health and pregnancy success as well.
A large 2022 meta-analysis found that people who consume the highest amount of olive oil were 31% less likely to develop cancer. This may be due to the antioxidants found in olive oil, which may help reduce oxidative damage caused by free radicals, which is a leading driver of cancer. And a 2023 study found that olive oil was linked with lower inflammatory markers in people with rheumatoid arthritis, especially for those with severe disease activity. In fact, olive oil is mentioned over 160 times in the Bible, highlighting its crucial role in cooking and even medicine. But the olive oil they used back then isn't what we get today in the store. The olive oil they used back then contained compounds that could kill harmful bacteria. One of these is H. pylori, which is a bacterium that lives in your stomach and may cause stomach ulcers and even stomach cancer. Sadly, the olive oil off the fluorescent lit shelves today is, kind of rancid. And all the beneficial compounds I just mentioned are most likely gone, oxidized, and I didn't even know I was consuming rancid olive oil. Even the high-end, quote, clean, well-known brands with single origins, I literally myself was consuming this many years ago, and that was before I discovered Casandrino's olive oil. Their oil is completely different. They own their own farm in Greece, harvest their olives, press the olives, and bottle their extra virgin organic oil all in the same day, just like they did back in Bible times. So you are getting the freshest, cleanest, and highest antioxidant olive oil available. This stuff is like medicine, and you can see and taste the difference in color and in the way your body feels when you consume it compared to many other olive oils on the market. Trust me, I've done it. So stop buying rancid, oxidized, old olive oil from the store and get the freshest olive oil to benefit your gut health, skin health, hair health, and of course, your meals will taste 10 times better. Get 25% off if you go to casandrinos.com/digest and use the code digest at checkout. You can also click the link in today's show notes, which will take you automatically there, and the 25% off discount will be automatically applied. But again, you can go to kasandrinos.com/digest and use the code digest at kasandrinos.com. Okay, the $1,000,000 question, Natalie. So obviously everyone, if you are trying to conceive naturally, there's so many females and women out there doing their best, right? To remove all the toxins and eat the best. Why is it that more often than not, I'm seeing women who eat like crap, eat fast food, hardly work out, use toxic cleaning products, toxic makeup, wear polyester, drink alcohol every weekend. They were even on birth control in their 20s, and all of a sudden they just get pregnant without even trying. And here, so many other women are doing, quote, all the things right, and they're still trying to conceive. Like, how come all of these people that are like not even trying to conceive and live a, quote, dirty lifestyle, and they have no issues? And then there's women that are like, I'm doing everything right. How come I can't?
Infertility is certainly not fair. And even if there's a lot you can control, you can't control everything. And there's a bajillion N of ones, meaning this person got pregnant doing that, and this person got pregnant doing this. When we look at population-based data, people who eat more ultra-processed foods, who, use cannabis, who drink alcohol, who, live this, quote, less healthy lifestyle, absolutely have a harder time conceiving, more infertility, takes longer to get pregnant, and poorer IVF outcomes. But it's hard because we're influenced by these N of ones. We know this one person who did all those things anyway and didn't have any trouble. And it feels like the ultimate unfairness to us. What I would say on the other end is that I have a lot of patients who say they are healthy and they think they are. And when we break it down, they're not. And I think that is saying for a lot of us, and I'm going to put myself in the box, the classic phenotype for this person is the very high achiever who has a ton of stress, is trying to mitigate it, but maybe not getting enough sleep, has, historically run on too little calories during the day, trying to eat, more at dinner, maybe doesn't have the most nutritionally diverse diet as far as getting, micronutrients. There can be underlying nutrient deficiencies and even insulin resistance, even though we're thin, because of some of this dysfunction, and who's often not, picking up weights, lifting weights, building muscle. And so when we start looking at some of these tenets, they may appear healthy and they're trying to do all the right things, but sometimes we're missing still this core piece of the puzzle when it comes to metabolic health because of things that we've normalized in this society. We've normalized hustle culture, not getting enough sleep, going on long runs, we've normalized intermittent fasting where so many patients that I see don't have any food until, afternoon. And they're like, oh yeah, I just intermittent fast. I have these long fasting intervals. Well, as we said earlier, that can trigger the hypothalamus that maybe you're not getting enough calories throughout your entire day. Women have such a different set point than men for certain things. So that's not to blame anybody. I mean, I had infertility myself, but that's to say awareness of the fact that we all are our own N of one experiments. And regardless of what happened to anybody else, your health journey is nothing but your own. And especially when it comes to your fertility journey, this is your family at the end of the day. And so we owe it to ourselves to know all the factors that can impact getting pregnant or not, success rates or not, that we get a full evaluation so we know what we're dealing with. We understand the treatment options. When I have somebody say, oh, I don't want to do IVF. I mean, I have patients who say that all the time. And I always say, look, my job's not to force you to do IVF, but I don't want you to say you don't want to do it until you understand what it is, right? Let's at least explain it. Let's walk through the process, how it could help you. Sometimes there are ways where we have, ethical or religious or moral reasons why we don't love IVF. And sometimes those can be mitigated. I have patients who limit the number of eggs they fertilize, or we approach genetic testing of embryos differently. So there's always room for personalization, but we want to live in the world of, we want to make data-informed decisions. And ultimately, I'm not here to tell you, this is it, this is the only thing to happen, you have to do this. But I want to say, this is what's happening in your body. I want to test for everything we can. I want you to control all the factors outside the office that do impact your odds of success. You have to know about them first. And then I want you to know what treatments we can and can't do. The reality is, I have so many patients who come to see me and think I have so many things to offer, meaning I can test some things. But from a treatment standpoint, we've got medications to help you ovulate, IUI, putting sperm inside the uterus. Sometimes we do those together, IVF, and surgery. Like, outside of finding a specific abnormality, such as like an abnormal thyroid or a vitamin deficiency, the actual reproductive treatments that we have, it's not a huge list. There's very few things on that list that can start to aid us. And IVF is the only one that exceeds natural conception rates, meaning all the others are just trying to get you back up there because we've identified a problem. So we just want to be having fertility discussions more upfront. I'm a big believer in more proactive testing so that you can make those personalized decisions. And especially if you're going through IVF, or you're struggling, or you're starting later, or you have low ovarian reserve, trying to, quote, do all the things right, it's going to at least give you the peace of mind to say, I did everything I could. Because, we can't always control the outcome even when we want, but we want to control the journey. We want to say, hey, I did everything I could. I made good decisions from a place of data. I felt comfortable with the journey I walked, instead of, again, being at that other place saying, gosh, I wish somebody had told me that, or I wish I had known. So I think the heart of your question was why do some people get to do everything wrong and they still get pregnant? That's part of population-based data. There's always people who are outliers. We just want to use that data to help guide us on our recommendations and our choices.
Yeah. I also think too that some people can detox a lot better, like their detox pathways are a lot better than other people's. So even though they're eating the junk, they can detox it a lot better than like maybe you and I can, like we have to be really careful.
I talk about this sometimes and I say, we all have a different layer of what we call like our inflammatory burden. Like, we kind of have at baseline. We add to this puzzle if we, don't sleep, or we're exposed to this, or we're exposed to that. But the world is inflammatory. Like, we're exposed to things every day. And what we're trying to cultivate is this resilience within our body where we're challenged. We'll use, whatever the challenge is, a toxin, a cake, whatever. And then we recover from it and get back down to our baseline. And there's different things that influence that resilience. And that's what we're really trying to cultivate within our bodies. There's underlying disease that often is not diagnosed. There's endometriosis, adenomyosis, PCOS, hypothalamic disease, autoimmune disease. All of these things impact our odds of success that often, in the quote, person who's doing everything right, there might be still something that's causing them to be in this circumstance that we may not always get to the answer. It's one of the hardest things about this field. I joke about my friends who are in other lines of medicine of 99% success rates and always get an answer. Unfortunately, that's not women's health, but we should do our due diligence to make sure we're looking for those things or thinking about them if they are hard to test for. So we're making really proactive choices.
Okay. What if someone has nutrient deficiencies? Would you recommend IVF for them, or would you recommend, hey, let's fix this issue first? Like, let's say someone has been trying, right? They're like, I've been trying for years. I am deficient in X, Y, and Z.
Yeah.
Would you still recommend IVF because it could maybe, trickle down to the baby and they're not getting the nutrients?
We know even with IVF, we'll use vitamin D deficiency, that there is lower chance of success and poorer pregnancy outcomes, even in the setting of vitamin D deficiency. In the perfect world, we would correct this and then do IVF, or correct this. And we'd love it if you would conceive naturally. The reality is everybody's on a different timeline, though, and has different circumstances. So what's your ovarian reserve, partner sperm count? Are your fallopian tubes open? I don't love the rush to IVF without giving the opportunity to investigate the other causes. And the reality is a lot of them can happen concurrently, Bethany. Like, if I just told you IVF takes 4 months, like, there's a lot of things that if we know about it, we can start to change while we're on the process that are putting us in better health by the time we get pregnant. But you can't change it if you don't know about it. It's not to say, oh, if we correct this, you'll absolutely get pregnant and you no longer need IVF. I mean, maybe that's the case for some people, But it's really a nuanced approach where we want to look at each person individually, but we don't want to dismiss either aspect. I think there's circumstances that you can find yourself in. And I never want somebody to feel shame that they did IVF or feel like, oh, should I have not done that? Or, oh gosh, can I not get myself healthy enough because this is what I still have to do? So I never want us to have that mindset from it. But I think the true answer is, both is what we want. I don't want to force anybody to do IVF, but we've got to keep it on the table as an option. And we have to respect that there's different circumstances and timelines that we find ourselves in. But we want to make sure that we are looking for other causes and fixing those things, especially to your point, things that influence, baby's long-term health as well.
Yeah. Okay. So what is AMH and how does that affect fertility?
Great question. AMH is a blood test. It stands for anti-Mullerian hormone. It is officially a marker of what we call ovarian reserve. If we think back to the ovarian vault analogy, when you have more eggs remaining, so in general, when you are younger, the vault is more full. As eggs come out of the vault, it gets emptier over time. Well, every month you have a different number of eggs released, and that is proportional to how many are left inside. So if we put it really simply, when the vault is more crowded, more come out, and when the vault gets emptier, fewer come out. So we can test the eggs outside the vault and use that as a surrogate marker for how many remain. We can test them by either counting them on ultrasound. This is called an antral follicle count, or by checking AMH, which is anti-Mullerian hormone, in a blood test. Important ideas. AMH is a reflection of how many eggs are outside the vault. There's month-to-month variation, so that number's not perfect, but it's giving us an idea. And I like to think about it as a category. Average, above average. If you have an abnormal AMH, like let's say you have a low AMH, you're not going to get as many eggs per month. Like if we do IVF, you're going to have fewer eggs to work with, which does influence how many embryos you might have and rates of success for IVF per cycle. But on a bigger marker, you're probably going to go into menopause earlier. If you have fewer eggs now, you have fewer eggs in the vault, you're going to go into menopause earlier, have less time to complete your family. And that's an important piece of the discussion right now. There's nuance with this, meaning right now, the American College of OBGYN says that women should not have their AMH checked unless they have infertility or struggling to get pregnant. Infertility defined as trying to get pregnant for 12 months and not having success. Their argument here is that one, having a low value can be stressful, cause undue stress. And two, that women with a low AMH can still conceive. And that part has some merit to it. I think one, the assumption that this information is too stressful for an individual woman, I don't buy that. I think if we take the time to educate women on what it is and not, they can make their own decision. And I'm going to counter with, you might absolutely make different decisions from this moment forward if you have this piece of the puzzle. So if we use the vault analogy and I say an average 20-year-old would have, or if I average 30-year-old will say has 20 eggs outside the vault. So normal, one would ovulate, 19 would die. Now, if she has a low AMH and she only has 5 eggs outside the vault, gosh, she's going to go into menopause earlier, not going to get as many eggs for IVF or egg freezing, might need more cycles. But if she's still ovulating, in principle, they're both ovulating 1 egg. So they have the same monthly odds of trying to get pregnant if they have no other medical factors. The big issue with that statement, even though it's true, is that things that cause you to have a low AMH, many of them cause infertility. Autoimmune disease, endometriosis, smoking cigarettes, exposure to certain toxins. And by not giving the woman to say, oh, you have a low AMH, let's look for autoimmune disease. Oh, you have Hashimoto's. Well, that can cause infertility, make it harder to get pregnant, also impact your health long term. You might absolutely have a different health trajectory the earlier you are when you get that diagnosis. And then we have the power to make a decision, meaning you might say your AMH is low. Are you in a relationship where you want to start trying sooner? Like that could have been me. I was married for a really long time before we started having kids. And had I known, oh, your AMH is low, maybe I would start earlier. But based on where you are, maybe that is something we should consider for you. Maybe you do nothing, but maybe gosh, I may not have as big of a family size, or I might need thinking about this on a different timeline. Or I'm going to really focus on egg quality since numbers aren't in my favor. I really need to make sure I don't have an autoimmune disease and I pay attention to my nutrition and my gut health because I don't have as many eggs to work with. When we take that opportunity away by, as a field, saying, we're not going to check this blood test until you have failed to conceive, I think it's extremely paternalistic and misogynistic. I think we are really losing one of those few warning signs that we have from our body. And there's so little we can test when it comes to our fertility that it's not a one size fits all approach. But to me, this is your body, your data, your ovarian reserve. And even if the test isn't perfect, to say that it's also maybe a warning sign that other things are happening, we should individually be able to make the decision with what we do with that data. But you have to have that data point to even have this discussion.
Yeah, I think that's a great point to really just get checked. If you are, wondering what's going on with my body, and maybe having that information can really turn the table for you in the best way. And I also had a question, because I know that you are born with all the eggs that you have for life. And my question is it safe to say that some women have infertility due to their mother's health habits when she was pregnant with them? Does that make sense? Because, obviously what we do when we're pregnant impacts the baby, and the baby is going to have their eggs just as they're born. It's there. So what's the deal? Is that true? Or should we just really not bank on that?
There's absolute truth to that statement. And the way to kind of think about it is, yes, you have the most eggs you're ever going to have when you're a 5-month-old baby inside your mom. That's usually 6 to 7 million eggs. By the time you're born, you will only have 1 to 2 million. So if we think about this vault analogy, they're starting to come out of the vault. Even then, they're highly influenced by the world around them, which is influenced by your mom. And we have data showing that exposure to certain things, whether it's high insulin levels, whether it's BPA, certain toxins, can influence ovarian reserve in the offspring. Meaning, especially in animal studies, we have a lot of data, but we're even starting to see in population-based studies that women whose mom had high insulin, had insulin resistance, they are more predisposed than themselves to have PCOS, problems ovulating, and have a different reproductive health journey because of the environment of their mother. And well, we can always go blame our mom, but we can't do anything about that, in this generation, things that your mother had. But I think it is highlighting the fact that I don't ever encourage somebody to, let's make this health change to get pregnant. One, we should do it for your entire life. Because we want to be our healthiest self. We want to live long, be healthy, functional as long as possible. But also these anti-inflammatory health changes impact you now. They impact your ability to conceive. They impact your pregnancy. They impact your child. And so really cultivating the world we have created, the world that we've been born into, really is one that is not conducive to how our bodies were meant to live. And we can't go and change the world. People try, but one thing we have to at least do is be aware of it. And we have to actively then make choices to lower that inflammatory burden, to treat disease, to lower insulin resistance, to avoid toxic exposures when we can, so that our children can have the best health outcomes later in life.
Yeah, yeah. And I want to really bring up birth control, hormonal birth control, because I think there's a lot of misconception. And I'm going to state this. I Googled this question, okay? And
oh dear, Bethany, I'm scared now.
I know, because a lot of people, they use Google, they use whatever, ChatGPT. And so I asked the question, does birth control cause permanent infertility? And then this is the answer. It says, well, that's a myth. Long-term use of birth control pills. This is the myth that long-term birth control pills will cause trouble getting pregnant later. And they're like, fact check. Most forms of birth control do not have a long-term impact on fertility. Often, you can get pregnant shortly after discontinuing birth control. And I feel like that's so skewed, because I've known so many people and they're like, I was on birth control and now I can't get pregnant years later. What do you say?
Yeah,
what do you think about that?
There's a lot that goes into this discussion. One, because birth control is a big word that means a lot of different things, and there's a lot of different types of birth control. So that has a lot of nuance to it, and we need to break it down. Let's also say this. Infertility is not getting pregnant at 12 months. So when these studies, and there have been robust studies, thousands and thousands of patients looking at, do you have a higher rate of infertility after stopping contraception? And no form of contraception on the population-based level has a higher rate of not being pregnant at 12 months. Okay. With that said, we need to look within each birth control individually, and also why you are on it, which I think is one of the big pieces of the puzzle we're missing. The birth control pills that people are most commonly talking about or most commonly prescribed, it is a synthetic ethinyl estradiol and type of progestin. These hormones tell your brain that they don't need to send out any FSH or LH, therefore you do not ovulate. The birth control pill has a half-life of only 28 hours, so it is out of your system relatively quickly. It's not perfect. It can cause certain nutrient deficiencies, it mismetabolize in the liver, can change how your body functions in some certain ways, but it's a very effective contraceptive choice. One of the biggest problems with the birth control pill is not that it needs to necessarily be cleansed out of your body for a long time, but it's that your brain and ovary have now not communicated for years. And we're asking them just to communicate again. And you don't know how to track your cycle. We don't know what's normal for you. We don't know what could be abnormal. But more so than that is the majority of women of our generation were given a birth control pill for a medical reason, not just contraception. And they never had, and I'm not saying it was wrong. There are certain medical conditions which birth control, can help somebody, but it's the lack of the informed discussion saying, hey, Bethany, I think you might have endometriosis, and, this is what it is, and this is how we can look for it, and the pill might help in this way. However, this is still going to be a problem when you stop the pill that needs to be addressed, whether we do it now or we do it then. And I would stop the pill this long before you want to get pregnant, and we can run these tests, right? That's the missing piece of the puzzle. Most commonly with women with PCOS, ovulation issues, and endometriosis, who are handed a prescription for a problem, no diagnosis given, unaware they even have it, even if their doctor's thinking, this sounds like PCOS, given the birth control pill. And then when they stop the pill, they're like, oh my gosh, I have acne now. My periods are really far apart. I'm gaining weight. It's the pill caused this. And in that case, the reality is that these problems were the disease. The pill was the Band-Aid for it. Not saying it's wrong, but you deserve to know what the disease was. There were lifestyle things you could have done that entire time that also could have been helping you, so that when you were stopping, we knew, gosh, I like my PCOS patients to stop the pill 3 to 6 months before they want to conceive. We got to really see where our cycle pattern is. We've got to go check a whole slew of things in blood work to see kind of our new baseline once we come off the pill. But instead, I'm on my soapbox now. I can tell because I'm rambling really fast.
I love it.
But now what's happening is that you're given this, you don't know, you stop the pill, your periods aren't coming, you go to the doctor, they say, it's just stopping the pill that you use for so long, give it longer, you give it longer. These months and months, a year goes by before you finally get to, oh, you have PCOS, which really we could have gotten that diagnosis a decade ago. It's really unfair. And that's one of the biggest issues I see. A couple caveats to this is that the progesterone IUD, the Mirena, there's other versions, Kyleena and others, is a progesterone-based IUD that goes in the uterus, can severely thin out the uterine lining, can change endometrial receptivity. And even though you can get pregnant immediately upon pulling it, for the majority of women, it takes at least 6 months, if not longer, to get the lining to build back up to normal, and for the genetic code of the endometrial lining to restore to one that can be suitable for implantation. So I always want people to remove a progesterone IUD at least 6 months before they want to conceive. And this is where that infertility data is a little nuanced, because you might have lower odds of conceiving for 6 months. Well, you might get pregnant in the back end, so by 1 year, it doesn't look any different, but that doesn't mean it's exactly the same. You might have had a longer time to pregnancy. It might have taken you longer to restore your period. And these are things that, had you known, you could have pulled your IUD earlier. And then also, if you're not having a cycle on an IUD, which is the case for many people, again, you're losing that awareness. When do you ovulate? Are you even ovulating? If you pull the IUD and you're not, that takes time to work up. And then the Depo-Provera shot, that's the progesterone injection that lasts for 3 months, and you have to get it every 3 months. Not as common anymore, thankfully, but one single shot, even though it's only proven to prevent ovulation for the majority of the population for 3 months, you have to get every 3 months. One single shot can prevent ovulation for 18 months. So this is one where you should not be getting that if you want to conceive in the next couple of years. So a lot of words coming out where I think the biggest issue here well, it's really on both ends. I also don't love villainizing birth control either. Women need to make choices that are right for them. But the biggest problem in my mind is not
Informed consent.
100% not getting to a diagnosis or even trying and not having an explanation about what will happen when you stop it or when you should, and really kind of putting that decision to us who's going to be using the birth control about symptoms, side effects, risks, why we're using it, how it can help, what could be underlying, and what that could mean for us when we want to come off of it and have a family. There's a much bigger discussion that needs to be had there.
Yeah, I think the lack of informed consent is a huge pet peeve with me in the medical space or even like just the health and wellness space. Like, look, if you want to eat this food, fine, but like, here's the ingredients, here's what's going to happen to your body from X, Y, and Z. Now it's up to you, right?
Again, I give you data, you make decisions, but you need the data to make the decisions.
Right. Okay. Do you have time for one more question here?
Yeah, we can do one more.
All right. I want to know, what are some, quote, healthy habits that we are doing regularly that are actually making it harder and hindering getting pregnant? Like, for example, I've heard coffee can actually hinder, like things that you think are healthy that are actually sabotaging.
Good question. Let's do coffee. You said that one. We like caffeine intake to be less than 200 milligrams a day. The biggest problem here is not coffee you might be brewing at home, but a lot of times this is from coffee shops because not all coffee is created equally. A shot of espresso has 75 milligrams of caffeine on average, but a drip coffee from Starbucks that's a grande will usually have well over 300 milligrams. So your 1 cup of coffee might be well exceeded depending on the coffee shop. So I always say proceed with caution. And then I think I have to add in the same sentence that I drink black coffee. I love that, but I know that's not standard. So a lot of people like to add sugars and flavors and whipped cream and all kind of things to their coffee. And so we have to understand that that itself has influence as well. I think number 2 I'm going to put to the list is going to be like healthy foods, but they're processed foods, things like protein bars and other things that are highly processed. They have, wrappers too that can have toxins in them. And there's times for that, meaning you're traveling, you have this, you have that, where we need convenience foods. And again, we're looking to build that body's resilience. So that should be okay. But, when you're in your home, you're working from home and you have a pantry and you have a refrigerator, like go to those sources for those foods and not thinking like, oh, this is a healthy protein bar. Whole foods are always going to be preferred to those that are processed. And then, things like sauna.
I was just about to ask sauna. Yeah.
So these are nuanced. And so for women, sauna is fine. We don't want to use the sauna once we get pregnant, but in the preconception phase, sauna can be really beneficial for stress levels, for inflammation, for healing, but not for men. I always get asked now, like, what if I put a cold pack on my balls? And, there's people who are doing that in their own N of 1 experiments, but in general, the scrotum's outside the body for a reason. Sperm need to be created at a lower core body temperature, and we don't want to be elevating that, or it does influence sperm development. So for sauna use, women while trying, yes. Men while trying, no. Cold plunging is another one, though, for women. We don't really love to see cold plunging for the majority of women. It typically is a big strain for your hypothalamus, especially if you're trying to conceive and have hormonal balance. And so it might be something that you love doing, but in this season of life, again, we're trying to convince your brain that the world is stable and the stable world doesn't fluctuate temperature that abruptly, right? That quickly, that abruptly. And that can be a huge hypothalamic strain. Another one that we mentioned earlier, just to say, would be that fasting intervals. I don't like fasting intervals of more than 12 hours for women who are trying to get pregnant. So that, intermittent fasting interval of 16, 18 hours for the majority of time, that's actually not going to be advantageous for us.
Okay. And what about going vegan?
I think you can absolutely be vegan and eat tons of processed junk food and have it be bad. You can be vegan and have a beautiful, rich, plant-based diet. Of course, we have to be aware of, vitamin B12 and make sure you're getting enough choline. And so there's some nutrient needs you have if you're vegan, but it's also not inherently good or bad, right? Like we really want to step away and say real whole foods, fruits, vegetables full of fiber and nutrients need to be a part of the diet, no matter what dietary category we are choosing to partake.
Okay. I love it. Thank you so much, Natalie. I know you're pressed for time, but I really appreciate you coming on and just sharing your knowledge. Where can people find you online, on social media, all that good stuff?
Thank you so much, Bethany. I feel like we could have talked for hours, so love it. I'm online at Natalie Crawford MD on Instagram and all social platforms. The website's nataliecrawfordmd.com. My book is The Fertility Formula, and you can get that anywhere that books are sold. And again, thank you for having me.
Amazing. We'll put all those links in today's show notes for those listening, that you can go to today's show notes and just find Natalie with one easy tap. Thank you so much for coming.
Thank you.
Thanks for listening to this episode of Digest This. If you enjoyed this episode, please leave a review in your podcast app to let us know. If you're ever wondering how you can support me and this podcast, sharing it with your friends and family is the best way. This is a Wellness Loud production produced by Drake Peterson, and to check out more shows by my team, go to wellnessloud.com, and to email the show, message us at digestthispod@gmail.com. See you next time. The content of this show is for educational and informational purposes only. It is not a substitute for individual medical and mental health advice and does not constitute a provider-patient relationship. As always, talk to your doctor or health team first.